What story are you telling? It's like, this is the piece. Sometimes we're not telling our story correctly. Sometimes we're telling it from a different viewpoint. It needs to be somebody else telling the story. So I love this conversation that we're having. You specifically, predominantly understanding the home care space, the hospice space.
Even though it is burdensome from a documentation standpoint, I do think it is incredibly important to continue to capture that data because it tells many stories. Like you said, it tells a clinical story.
Well, welcome everyone. So glad to have a special guest that some people and many that may be watching this have never seen before. So number one, gonna have her introduce herself, but welcome to the Leadership Lab. And we're here again talking about mobile integrated healthcare, community paramedicine, the intersection that this space has in the healthcare continuum. So first of all, I just want to say thank you for joining me today. So Brandy, I'm going to ask you to introduce yourself. Introduce yourself to people that may not know you and tell us just a little bit about who Brandy is and what you do and who you work for.
Yeah, sure. So Brandy Beierle, I am a registered nurse. I work for Home Care Home Base as the Chief Clinical Officer. My experience has ranged from the emergency department all the way to hospice care. I think that working in the home truly gave me a different perspective. I think being able to meet patients in their most sacred place and really help them navigate the very complex, fragmented systems that they have to participate for their care in. And I got to lay witness to that, and I still do. And so being able to take that point of care experience that I had and my love of technology and making sure that we're leveraging technology to connect that care led me to my role at Home Care Home Base.
So I'm going to explore that just a bit for our listeners because they're starting to hear a central theme around data and this intersection with clinical care. And I like the statement that you just said about my love of technology, and I'm paraphrasing, and that love of care and the intersection of it. So let's go back, just rewind a little bit back in your history. You don't have to date yourself or anything like that, but tell us what got you interested in nursing and in patient care, or was it the data side of it? Tell us a little bit about who Brandy is from that perspective.
Yeah. So when I was 9 years old, my grandmother lived with us and she was on hospice care. And she had a fantastic LVN named Vonda. And I got to watch the power of hospice. We don't do a good enough job telling the hospice story. I won't talk about it today, but I got to actually personally see that through my grandmother's care. And I got a little bit older, and I'm from East Texas. And so you kind of typically have two paths. You can be a nurse or you can be a teacher. And so I said, well, I guess I'm going to be a nurse. And so fell in love with home health and hospice. Like I said, just it's an incredible experience meeting patients where they are and guiding them in their care journey. And then I started to understand that actually data is such a large part of a patient's story. And actually, I don't think we even today fully understand the insights and the impact that data can have. And so I was like, well, I was in population health at the time, and it just occurred to me that data is so, like you said, so incredibly important. So when I got ready for a career change, I was like, where can I still impact patients in the home? How can I actually promote data in a way that's connecting patients to the right care at the right time? And how can I advocate for a true care team model in the home? Because I think we have some work to do there.
So let's talk about that. Let's dive in because that's what people are really interested about, this intersection of like home care, because a lot specifically in the ambulance industry have been talking about this. So first of all, I'm going to ask you I just want to kind of dive into the data side of it. And then I'm going to get into how is this transforming some of the care clinical models that you're paying, how you've intersected with EMS. We're going to get into all of that for those that are listening to it right now. And I'm sure they're going to have a lot more questions, but we only have a certain amount of time on this podcast. But I want to start diving and start having this conversation because we talk about it, and I'm probably going to bring it up on every podcast about about how our industry with EMS, that's my background, we've generally thought we're the heroes. That's kind of what we always have seen ourselves, whether I'm in a fire EMS model, whether I'm in an EMS only model, understanding this. And this is something that our company has traditionally been. If you heard a podcast that I did with Dr. Beck, we did talk about the story branding concept. And that is sometimes you're the guide and somebody else is the hero. And it's hard to put on those different paths. And I think we're struggling with that as an industry because sometimes we're not the hero. Many times we're not the hero. It's the patient that's the hero. It might be the insurance or the payer that's the hero. It might be the regulator that's the hero. And so how do you guide them through this transformative care that we're doing? We're more than just you call, we haul type concept. There's a lot that EMS can do inside of the home. So we recognize that. So I want to take it to data first. Let's go back to data. I'm asking everybody the question. You brought it up.
Okay.
That's a passion of yours. So talk me through how you're using data and why it's so critical in in-home care. Like, explain to me about that piece and why it's important for outcomes. It might seem normal for us, but talk me through why that's important. And then this, I'm not calling it a marriage, but this work that you're doing with the data to understand that piece. Let's talk a little bit about that.
Yeah. So we'll use home health as an example. We have an OASIS, and it is the richest data set that Medicare actually has. And I can remember getting into home health, and they handed me a piece of paper. I'm going to date myself, so I started out on paper. 16 pages long. Standardized data set asking very specific clinical questions that are tied to a risk stratification and a functional score that a reimbursement model is built around. So even though it is burdensome from a documentation standpoint, I do think it is incredibly important to continue to capture that data because it tells many stories. Like you said, it tells a clinical story. It actually tells a reimbursement story, and it tells a quality story. And so you have three heroes going on at the same time with the patient in the center of that specific assessment tool data set. Having worked with EMS and being EMS friendly, NIMS is okay, but there's a wall there. You guys are in every zip code in every city, and you have an opportunity to collect very meaningful data from an outcome perspective, from a reimbursement perspective, and from a clinical perspective. And wouldn't it be super cool if, from a policy standpoint, if you could capture that data and make it more meaningful for those three kind of buckets? And I think that's where we kind of have a disconnect. And we can change. I mean, I think we have a really unique opportunity. It's there. The people are there. The data is there, I believe. It just needs to be restructured and make sure it can be stratified and make sure it kind of checks those boxes of, are we getting reimbursed beyond being an emergency transport company? And I think the way to do that is actually get a more rigorous data set that EMS providers are there. You might as well capture it and begin to really tell that data story, because EMS always answers the call. No matter what, you have to answer the call. So if you're answering the call and your communities trust you and your patients trust you, why can't we get insights into that so we can take better care of people? And it's not a competition. Home care providers shouldn't be scared of what an EMS provider can do, and EMS providers there just shouldn't be that friction. And I think there is in a lot of ways, but I am totally open to tearing those walls down and really creating a seamless longitudinal record that the EHR kind of is the center of that, because that's the story.
So you're getting me excited, and I'm trying to sit here to listen because I want them to hear and understand what you're saying. But
Yeah.
I want to ask a few questions. We talked about the data piece of it, because you talked about the longitudinal piece of the data record. And the EPCR is actually in the middle of all of this. But it's not the EPCR that EMS is thinking of. It's a more holistic, and there's a lot of data companies that have been working on this. Epic and Cerner have been trying, but they're more targeted in a much larger system. And then you're actually moving in. How do we use our medical records in EMS to work? I know there's been a construct been thinking about, because I can see it, that your data, you've integrated, you've been working with ESO on certain things and other vendors. What are we doing there? Because I think that the people that are listening, because I'm going to have people that are like excited, finally, we're having this conversation. This has been a discussion that we're having. But policymakers need the data.
They do.
Whoever provides the data is getting reform in their systems. There's a reason why we're not getting reforms, because sometimes it's anecdotal. Sometimes it's just a provider's data. It's not a system of, does that represent the whole? And I think those are the challenges of the wall of NEMSIS. I'll say the NEMSIS issue, you brought it up about, because it is.
Yeah.
There has been some conversations. I know a lot of my good friends that work at NHTSA, they do stuff with the NEMSIS. I get it. There's a lot of work, but it's not married to the reimbursement yet. And there's a work to happen through the process and engage. Tell me in your vision, and I know it's like in my crystal ball, this is what I would see as being very effective in this because of your integration and working with CP and paramedics and stuff.
I think if you put the patient at the heart of it and you think about data telling a story, the data becomes a storyteller. And it has to be actionable. I think data needs to be actionable. And I think what I'm hearing you talk about is from a regulatory standpoint, the regulators have to know that you're providing a meaningful service that drives outcomes that they can feel good about paying you at the end of the day. And I think that even in home health and hospice, we have to continually advocate for ourselves. We have rich data sets, but we still have to go and advocate because we still have access to care challenges. But because we have that robust data, we're able to tell that story. So I would tell you is, what story do we want to tell? And it feels like the story that we want to tell is a comprehensive clinical model that's centered in the home, that has a robust care team that is providing the right care at the right time, and that the reimbursement structure's there, the data constructs are there, and we're driving better outcomes for healthier communities. That's what it feels like to me.
Wow. That was an incredible response. I'm sure we're gonna be talking about this. What story are you telling? It's like, this is the piece. Sometimes we're not telling our story correctly. Sometimes we're telling it from a different viewpoint. It needs to be somebody else telling the story. So I love this conversation that we're having. You specifically, predominantly understanding the home care space, the hospice space, the integration that CP and paramedics can have within the space. And there is enough in the healthcare continuum for everybody that really cares for that patient through the eyes of the patient to be involved in the process of helping that patient. This is something that Dr. Beck and I talked about on the podcast, was related to what problem are we solving? And you mentioned that as well. And sometimes the answer is different based upon the person. And this is where the industry has to unify to understand, can we agree and coalesce on maybe one or two problems that we're trying to solve? Not 20.
No.
But maybe one or two, because home health might be solving 3 and 4. Somebody else is solving 7, 8, and 9. And so when you're a part of the healthcare continuum process, you're not trying to solve the whole healthcare. Don't take that responsibility on. So let's talk through, when we talk about that and that connection piece of it, is there's a lot of innovation happening. We talked a little bit about the innovation that's happening in EMS. Unfortunately, about 55% of the programs aren't funded, and so they become unsustainable at that point. So that's why we're having these conversations. And some people feel like EMS is often overlooked. I'm not quite sure I agree with it on that, but I want to hear your perspective on it because you've been working so much. So how do you see EMS playing a role? What role do you see from your perspective? Whether I agree with it or not doesn't really matter. It's your perspective is saying, where does EMS fit in, you believe, this continuum of healthcare in the home and helping the patient, because the patient is ultimately at the center?
So I'm going to be a storyteller for just a minute about the impact that I've seen of EMS and hospice work together. So it's 9 p.m. Hospice patient is deteriorating. Families getting super apprehensive, even though they know that this is a part of the process. Knowing and reacting are two different things. And they pick up the phone. They call the hospice nurse. She's deployed. She goes to the home. They're still super apprehensive. When the hospice nurse is en route, they get apprehensive and they call 911. So the hospice nurse and the ambulance show up at the same time. It's at that point we make a really critical decision. Today, the structure is not in place to actually allow the best clinician to solve the problem, navigate the patient through the crisis, coordinate with the hospice nurse, and end the call. Today, that patient is put into an ambulance, taken to an emergency room, and their hospice benefit is revoked. 9 out of 10 times. That's a missed opportunity. We have to do better. There is a world, I believe, where an EMS provider could actually go in, mitigate the crisis, stabilize the patient, because they're really, really good at that. Even if it was a telehealth visit with the hospice nurse to make sure that she was connected, even if it's we're going to do this visit together, that can happen. But we just got to create a system. That's the whole, what problems are we trying to solve?
So I think you bring up a really good point, and anybody that knows me knows I have no problem having courage and uncomfortable conversations, because you just told a great story of what's broken in our healthcare system. And because my background is specifically policy and reimbursement, I know where the problems are. The problems are certain organizations, advocacy organizations. It's whoever controls the money controls the issue. And so sometimes we have to look and figure out, is this truly about the patient or is it truly about where the money goes? Now, I'm not asking you to align or say anything or comment about that, but this is something that we're seeing within this organization. I believe this is some of the concern that we've seen around what data is doing and what it's exposing, and it makes us uncomfortable because now we have to answer questions that we're really not sure about. And I may not agree with methods, but I understand why it's happening. And I remember one of my friends who's a state senator in the state of Texas. I won't say where because they might listen and then you can kind of figure out where it is. But he made a comment, said sometimes things have to be blown up before they can be put together again. I don't really like that construct, but I think data and the exposing of data provides a window into it. And I believe that's happening right now, that we're beginning to look and understand and have these conversations and say, have we designed the best system for the patient, or have we designed the best system for the EMS industry, or, and I'm being facetious, or the home health industry, or for the physician community, or for the hospitals? When you sat down and said, and I could see visually in my mind when you were talking, can I get the physician with the home health, the hospice nurse, with the paramedic, with the emergency physician in a room? Y'all could probably construct out the best design of treatment for that patient together collectively. And then we marry policy and reimbursement to that. And I think that's where we're trying to get, but we literally have got to get back to the basics. The wrong people are leading the conversation and narrative. We've got to get back to the physician community who know to do right by the patient. They really have the best when it comes to the design. Then bring in other people like us that say, okay, you've designed, and now let's kind of talk through how to work it. That makes us uncomfortable though, because we lose control of it. I have to put control back to you. And people that are going to be listening to this, some of my friends, don't shoot us. We're having a conversation to discuss that. We all know this really needs to happen. A lot of us talk in private rooms. I'm willing to get out there and get into real practical conversations to say there are people that are smart enough to do this. I can see you right now in this storytelling, and that's where I think this continuum is happening. When you are talking to me, there's smart people to fix this. The problem is, am I the guide or am I the hero? Is Asbel trying to be a hero? No, I'm not the one I'm not the message. I don't know anything about clinical care, but I know the one thing, but I do know who knows the patient more than anybody else. That's going to be you. That's going to be the physicians that care for that patient. That's going to be that hospice nurse.
Mhm.
They know, and oftentimes they're treating because that's the reimbursement flow. That's why they revoke hospice. And they send them in the back of an ambulance because, well, something's not going to get paid because somebody who's never been in patient care before but graduated from an Ivy League school. Yes, I'm saying it, and I love all my Ivy League friends. I'm just telling you I do. But the problem is we've got to marry the two.
Mhm.
And I'm being a little facetious through the process, but I think you're spot on too. That's a part of how the healthcare continuum. I'm going to move to the next question because I do want to understand, because a lot of people are talking about how do we integrate with EMS. You talked about it. You gave a great story because we learned by stories. So talk about an ideal use case for EMS integration that looks like in terms of both improving patient outcomes, but also supporting financial stability. So if you could wave your wand, knowing what you know now with data, and saying, if we put this together, there are some things that we have to do in order to maintain financial sustainability. Because I gave you the quote that just came out that the National Association of Mobile Integrated Health did a survey on, that 55% of these programs that EMS gets involved in actually are probably great concepts. They just weren't they weren't sustainable. So talk me through a little bit of that.
So I guess I'll ask you this question. I'm going to ask a question for a
Sure.
question.
I love it.
Is there a billing code today in EMS that would promote and support that community paramedic actually delivering care in the home versus them putting the patient in the back of an ambulance?
So there are some billing codes that could be tailored for the industry to bill for. Oftentimes, it's because they consider us as what we call a Type 41 provider, and so it has system limitations.
Okay.
That doesn't mean it cannot be undone, and this gets controversial because of who controls HCPCS and then the process that we have to go through. I know this is a frustrating element. It's going to be interesting to see how Trump 47 and his administration addresses that. But there are codes. Unfortunately, sometimes there are limitations in how the codes process through payer systems and government systems. So if you could eliminate that, it's a very telling question. I think we all know the answer to the question, and we know what is causing the bottleneck to that question. And I'm fine with having that very uncomfortable conversation. When I started answering, I'm like thinking, are you going to just say what you really think, Asbel, or are you going to articulate it a little differently? I'm going to be a little diplomatic because I don't want to be offensive.
For sure.
I don't want to be offensive to regulators and others but many times the innovation is inhibited because we have placed controls around things that really aren't helping the patient. It's more about protecting. So are we going to help or protect? Now, there needs to be guardrails. Nobody's saying there needs to be safeguards and guardrails. There are some protection guardrails that are not really meant there for the patient. And that is probably something we need to have a very much more robust discussion about, and frank conversations, and be okay with calling it out, but doing it diplomatically where people hear me. So I don't know if that answered your question, but
And the reason I say that is because I fell in love with community paramedicine and mobile integrated healthcare because I saw the value as a nurse. You guys are a fixed asset in every community across the country. As I said earlier, you answer every call. When the phone rings, you answer every call. There are a finite amount of home health and hospice clinical resources. In fact, we're in a clinician crisis in those two delivery models because we have to tell a better story about the value of that. And we could spend a whole another day on that. But because EMS is a fixed asset in those communities and you have to answer every call, it just makes sense to me. Like, I'm a cowgirl at heart. I live on a ranch, and it's very logical to me that why wouldn't you deploy and leverage fixed assets for unplanned, unscheduled care in communities across the country to help extend hospice clinical care, extend home health clinical care? It's a capacity game.
So you have identified the window that EMS should focus on, the unplanned, unscheduled.
That's my humble opinion.
I get, but I think you've identified what people need to pay attention. There's fixed assets in communities for unplanned, unscheduled care that could happen in the home, to where this is where the integration could happen with home care, with hospice, with whatever other myriad physician specialties are doing stuff in the home. Many times they need to schedule it out. I need to book it. I need a point. Whether it's even unscheduled, could be this is happening quickly. Sometimes people need 4 hours or 6 hours. We need to operate within that construct without saying, well, we can also do this for you. We can also provide this window for you. And then what happens is that starts encroaching on some other clinical specialties threshold. And so instead of them listening to the pieces where you need the help on, you're wanting to move 80 degrees when you should really only move 30 degrees, and it provides exactly what you're needing in your community with your fixed assets. I wanted to bring that point up because you're saying something that makes sense. I know that's your humble opinion. I'm regurgitating like to the industry that's listening. Listen to what Brandy just said here. Fixed assets for unscheduled work. That to me makes sense. It's like aha moments. But the problem that we get as an industry, we want to go from 0 to 75 overnight. Does that make sense? Yeah. And that's our industry. That's who we are as 911
adrenaline junkie. I mean, you absolutely want to move super fast. It's who you guys are.
and it makes sense. It's like, so calm down, come back, step down. Sometimes this adrenaline junkie gets in our way a little bit. I like what you're saying. And we methodically work through this process.
But I think that will begin to show the value and tell the story. Remember when I said, what story do you want to tell? What problem do you want to solve? We were talking about that. But I think that window, as you're talking about, fills a gap, that an access challenge and a gap and a capacity problem. And I personally just think that's what makes sense.
Yeah. And I think more and more that we talk to engage people, the conversation keeps up again. Some of us have been talking about this since 2010. And before then, before I even started talking about that, people were talking about it before then.
Yeah.
And it's 2025. For me, it's been 15, 16 years.
Yes.
I'm looking back historically. I talked about this as well, is in the company that my business partner and I own, we aren't looking at in like 15 years. Like, it shouldn't take 15 years to get it. Usually it's like we need to pivot. We need to do something different. Usually it's within 2 years, something's not happening. You better be pivoting quickly, or 18 months, whatever that ROI is. It's the same concept here. We keep talking about, well, if we just had more data, if we just had this, but what problem are we trying to solve? Dr. Beck said that in the very first episode that we did here. The industry needs to have frank conversations and dialogue that frankly is overdue on what problem are we trying to solve. We're trying to do too many things at one time. It's 1 to 2 or 3 things. So pay attention to what other people. I'm glad that you've come on the podcast with me. So I'm going to move on to a few more because I want to give it in the amount of time that we have here. As a chief clinical officer in your company, talk to me about some of the specific patient outcomes and measurement. You talked about outcome data. You guys have a host. Tell me what you guys look at, 2 or 3. There's some things that we talk about in the industry, some things we might be right about, some things we might be off base about, but I want to just understand from your perspective. Talk to me about some of those patient outcomes that you're looking for.
For sure. Yeah. Readmissions, huge. Readmissions for home health, revocation for hospice, basically the same concept. Unnecessary, unscheduled care at an emergency department that results in an admission, or even frequent ED utilization we look at. Those are kind of too big when we think about clinical outcomes and data that we look at. We've really been working on hospital risk, predictive hospital risk, and using the data to inform us even before we actually go out and admit the patient. Is this patient more at risk to actually have an event that drives them back to the hospital? And just like EMS providers, home health nurses walk into homes unprepared. And we are unprepared because we don't have a comprehensive data story, because there's these walls. So you and 911 might know that my patient calls 911 3 to 5 times a week for the same exact complaint. And you drive to her house and you pick her up and you take her to the emergency department. And this cycle goes on and on and on. And I, as the admitting home health nurse, have no visibility into that data. Do you know how powerful it would be if I had visibility into that data? Because I could collaborate with my EMS people and say, what do you think is driving my patient to pick up the phone and call 911 over and over and over again? Is there some clinical piece of data that we're missing? Is there some social determinant of health that we may not know about? How can we collaborate with our physician colleagues as a team around that data to provide better care? So predictive hospitalization is super important from a hospice perspective. Meaningful care at the end of life is something that is important from a publicly reported outcomes perspective, from a regulatory perspective. And so how do we get better at making sure we're arming that family and that patient in their last days of life with the care that they need as they transition? Those are kind of the big clinical pieces. You can get into missed visits. We want to make sure that patients aren't missing visits. Lately, we've been looking at access to care because I told you we don't have enough clinical resources. And home health and hospice, from a reimbursement and regulatory standpoint, is set up that it's very specific clinical resources that can provide the care. And unfortunately, today, that's not an EMS provider, even though it's a fixed asset in the community. And they're clinically appropriate sometimes, even more so than the home health or hospice nurse.
So this was not on anything. So most people think, is y'all just having this conversation, Asbel, on Leadership Lab? Generally, we have an outline, folks, that we kind of go through whatever. So I'm going to surprise our guest today because she made a statement here that I'd like to, and feel free, but I understand if you can't discuss it, but this is going to be another uncomfortable conversation, and I like to throw this stuff out there, and that is one around that sometimes the best policy, the best guidance is derailed because we have bad actors that enter the market. And we know that this has happened in the home health space. This happened to you guys, oh dear Lord, probably 20, 25 years ago. This was a big issue. And so, of course, ultimately, it's usually the fringe. It's never the whole. It's only the 10% or 15% of people or less that do that. We had this happen in the ambulance industry. And so instead of just addressing that small piece, they just throw in regulation that hampers everything, and it hampers innovation or what have you. How much of that do we see playing into, from your perspective, your background in EMS, that might be playing into why we're not seeing more functionality around the intersection, number one, of the data? So I've got friends that are going to be saying it's HIPAA, and we're seeing data that's come out here that's actually showing that there has been an increase in administrative overhead since the HITECH Act was implemented, the HIPAA was implemented. I mean, the data is the data. It's going to paint a picture. It's going to show you that when they implemented these things, we saw a dramatic increase in the administrative burden. So I get it. I think there's some misnomers out there. They need to clean that up, and there is some hope that maybe we'll see some action that start on there. But I know that's a little bit, and I don't want to surprise you through that process, but I do know that some innovation sometimes can be stifled because bad actors can move in. And when I've talked to regulators before, that's what they've said. We're a little concerned that this is going to happen when, for instance, the Office of General Counsel, OGC, or somebody else is opining on stuff.
Yeah. I think, Asbel, some of this, and I'll try to be super diplomatic, every clinical discipline has expertise and value. And sometimes there's perceived value and real value. And I think we have to start reevaluating true clinical value by specialty, by discipline, by team member, to make sure that what we thought 25 years ago, is it true, or is it a bad actor, or can we do a better job? Because I was taught growing up in home health, 911, you call them, they haul them. They'll meet you in the driveway. They don't even want your report as a home health nurse. Lots of friction, lots of territorial conversations. And I guess my heart as a nurse was always, well, that EMS provider probably has information that I need, and I probably have information that they need. So why can't we be friends and do what's right by the patient? But I think there's long-standing lines and walls that we have to unpack and reevaluate and think about care differently. So there's physician regulatory environments, there's nursing regulatory environments, there's paramedic regulatory environments, there's fire regulatory environments. So how do you get all those environments together, remove their hero hat, put on their guide navigational hat, and say, guys, we're at a place in healthcare where we have to do something different because we're not winning.
It continues to increase. I had a friend who's also a MedPAC commissioner talk in a conversation, it's probably a few weeks ago, that we need reasonable, and I'm paraphrasing, we need reasonable dialogue.
Reasonable.
And if you come with unreasonable, like unreasonable is saying, don't do anything, everything is fine, don't make cuts, don't cause us to do this, that is unreasonable in this environment when the data is showing that our cost curve is unsustainable. We have to do something differently. And how do we do that? Data is one of them. You can see the integration. How do we make this data available to consumers in more transparency? And how do we do that? Because we know data is going to start to paint a picture because John Q. patient is going to say, wait a minute. Why is this didn't happen? And that requires accountability. And when providers have accountability, now I got to come to that, and payers have accountability. It's the whole continuum. I'm not just picking on providers. It's everyone. And we sit at a table and we have these uncomfortable conversations because we have to have them. I want people that say, no, let's challenge the norm. I have to challenge myself all the time. We can't pay our employees if I'm not constantly innovating, if I'm not constantly bringing value. So what value are you bringing through the eyes of the patient? 2 years ago, that's what we pinned as a company ourselves. Everything that we look at is through the eyes of the patient. How does the patient perceive that? Not how our customer or client, how are we going to sell something that the patient perceives? That's kind of what we have to do. And that means I have to take off my hero hat so the patient can say, boy, they helped me through this process. I was up in Dallas yesterday, I believe, looking at a EMS's program, and they were walking through on a live call how all of a sudden they didn't have to send a 911 resource. This happened. I'm like, wow, that is solving the problem for the patient, but figuring out which problem it is. And that is what we have to do. We've got to break down the walls. And I think you hit it, because we all are entrenched in it. But we see a very interesting change happening. We see this happening in EMS. Because EMS is a relatively young industry. I mean, it really started out of the funeral home industry back in the 60s into the 70s. And we literally just started billing the Medicare program back in the late 80s. You know what I'm saying? And we moved into this new fee-for-service, which is a little different for home health. They're light years ahead of us. So we're trying to catch up. And there's other industries that are doing things, and it's saying, wait a minute, guys, do you not see the writing? Like, this is happening. Like, start moving. So we're facing that piece, but we've got to say, if we want to be a healthcare provider, we have to act like healthcare providers. And there's a different accountability for healthcare providers, that you have a perspective. And that's why I'm interested in having the physicians come forward. I'm having the nurses, because they're going to view things differently than Asbel's going to view it. Because you're a part of a different continuum. I want to kind of pivot here and ask you, in your current function with home care and the data side of it, how are you guys approaching this innovation and sustainability and stuff like that through driving better care? Forget about the EMS side. I want to get a window into your mind as the chief clinical officer. Like, what are you guys doing that says we are trying to drive better care for sustainability, things like that.
So you talked a little bit, I was actually looking at some data last week on reimbursement for home health and hospice. And there is a gap today with the current reimbursement versus the current cost. So there's inflation. And for many years, the cost of care and the reimbursement were running parallel, side by side, as well as the clinical capacity. So you had 3 tracks and they were running pretty equal and parallel. And about 10 years ago in home health, that the cost of care, meaning what it costs a provider to deliver home health, began to outpace the reimbursement. And at the same time now, there's a clinical capacity problem. So to deliver home health today at our current reimbursement structure is not sustainable, as you mentioned. So as a technology provider, how do we create technology that is meaningful to the clinician, but creates efficiency and capacity? Because we have to do that. Because the population is aging at a rate that we've never experienced before. We have access to care challenges. Today in the industry, we're probably turning away about 50% of patients into our ecosystem for a variety of reasons, but one of the top ones is clinical capacity. We don't have the clinicians to see the patients. And that's what we, from an advocacy standpoint, are really, really focused on in home care, home base, because we have that data and it's our job to shed a light on that in DC. Because we need to make sure that we don't continue to cut costs, because the cost of care continues to rise, the clinical resources to meet that demand.
So telling your story. Going back to telling your story, but using data to tell your story through this robust system that you guys already have, that we have challenges in our industry on where is that robust. Hence the reason why I remember reaching out to Eric saying, Eric, I'm talking to some of my friends who were I remember this was a year ago that I was having a conversation with someone that had been writing some of the rules around some of the transparency data. And they're like, yeah, y'all have data. We talked to Epic, we talked to Cerner, and I'm like, well, they don't really do a lot in the EMS space. Who else is in the EMS space? And nobody was there. I'm like, well, if you're not at the table, I've always been taught you're on the menu. So get at the table, and that was my whole conversation is saying, is I remember picking up the phone right away, Eric, why aren't you at the table? Now, it wasn't anything of anybody's own. It was just, it was that whole cognizant that said, you are the guys that are going to drive this. You have this most robust data set right now. No, a lot of my friends, there's a lot of, they're not, ESO is not the only EP, but that group needs to, we own the data. Then bring the clinical side in. That's what you're doing.
And you create, we participate in a quality alliance that actually our competitors sit next to us, and we all supply data to this quality alliance so that we can advocate in DC for the value of home health and hospice. But that's a story.
That's the story. And that's why you're able to provide, because you have a robust data set, not an anecdotal data set.
No. And it's very dynamic, because you got to remember that OASIS and now Hope for Hospice that comes out in October, that is a robust data set. And it informs the regulators, the payers. It is a window into that patient story.
Now, I could sit here and talk all day about this, because this is moving. This excites me to move the conversation, to provide ideas that I think our industry sometimes talks in silos. I like the analogy that you gave of the different walls. It happens even within your own industry, that walls are happening.
Yes,
how do we bring those walls down? How do we have these conversations? Like you're saying, I talk next to our competitor, but it's providing robust data into because it's helping everyone. The rising tide lifts all boats.
Yeah.
And in my opinion, that's where we've got to get to as an industry. And I believe we're taking paths to get there. I'm hopeful. I think we've got a window of opportunity to be involved, but let's not let that window pass us by, because anecdotally, some of this stuff is going to have to be done more at a very 50,000 foot view level. And then we kind of dive down because healthcare is always local. So I'm going to ask you, as we end the podcast or whatever, I want to ask you one question. First of all, thank you for taking your time to spend 30, 40 minutes with me today. But I want to tell you, if you had one piece of advice for us in EMS, and people that are listening right now about this mobile integrated health, the CP, us being involved in the healthcare continuum, what would it be?
So, Asbel, you said since 2010, you've been having this conversation. In 2010, I was a transitional care coordinator, and I worked alongside a community paramedicine program in DFW. 2010. This became a burn inside of me in 2010. We're in 2025. I have a son that's a firefighter, EMT, about to graduate paramedic school. It's really personal for me now, really personal, because I don't want him to be labeled as the you call and we haul. I want him to be seen as a part of a care team that meets a patient in their home and delivers a great experience and is empathetic and drives good quality outcomes. That's what my mom heart wants. So my piece of advice is build partnerships. Start having that uncomfortable conversation. Know your own data. Find the story that you want to tell, because it's there. And if you start having those uncomfortable conversations and you start thinking about care from inside the home out versus outside the home in, I think we can change it. But it's all about partnerships. It's all about telling a story. It's all about knowing your data, knowing what problems you want to solve, and then filling the gaps.
Brandy, I'm going to leave it right there. You made a statement at the very end, start having the conversations about inside the home out versus outside the home in. That's the difference in between being a guide and a hero. And so I can't say thank you enough for joining me today on the Leadership Lab.
It was such a pleasure.